Good afternoon. Again, my name is Dr. Stephanie Holt. Thank you for having me on behalf of the Neonatology Department. I will be talking about TIPQC, which is Tennessee's Perinatal Quality Care Collaborative. And I'll also be talking about two projects that TIPQC is currently involved in, the Safe to Sleep project and also the Opoid Use Disorder and Opioid Exposed Newborn projects. And I have no conflict of interest or financial disclosures. So the objectives are to define what a perinatal quality collaborative is, to learn about the Tennessee Initiative for Perinatal Quality Care, which is TIPQC for short, its mission statement and goals, to learn about the most up-to-date recommendations for safe infant sleep environment, and specifically the TIPQC Safe to Sleep project, and also to review the TIPQC Opioid Use Disorder and Opioid Exposed Newborn project. So before I get started, I just want to talk or show a video in general that talks about what a perinatal quality collaborative, if you're unfamiliar with what it is, and then I'll talk specifically about Tennessee's Quality Improvement Collaborative.
It's important that all pregnant women and newborns receive the best health care. This helps women have healthy pregnancies and their babies get a healthy start in life. Perinatal Quality Collaboratives, or PQCs, are clinical teams and public health leaders working together across the state to improve the quality of care for mothers and their babies. To help them accomplish their goals, PQCs partner with key state agencies and organizations, including hospitals, health departments, health professional associations, universities, state chapters of nonprofit organizations, health insurance organizations, and state Medicaid agencies. PQCs also partner with the families and communities they serve. How do PQCs work? PQCs often start by selecting projects that address major health problems for mothers and babies in their state. Then, they follow 3 steps to successful quality improvement. First, they recruit multiple hospitals across the state to participate in the project. Within each hospital, they empower multidisciplinary teams to apply various tools to quickly improve healthcare practices. Second, PQCs rapidly collect, analyze, and share project results with participating hospitals. This helps hospitals view their progress and compare it to other hospitals. Tracking progress helps hospitals identify opportunities for improvement and make changes as quickly as possible. Third, PQCs facilitate collaborative learning. The hospitals participate in educational webinars and learning calls to review their data, share best practices, and discuss opportunities for improvement. The number of state PQCs has grown considerably over the last decade. Most states now have active PQCs in various stages of development. PQCs have helped improve healthcare and outcomes for moms and their babies across their states. Some examples of PQC successes include reducing unnecessary medical interventions such as early elective deliveries, reducing infections in the Neonatal Intensive Care Unit, or NICU, and reducing severe pregnancy complications. CDC provides support to PQCs to improve the quality of care for moms and their babies, works with experts to develop tools PQCs can use to further their development, and supports the National Network of Perinatal Quality Collaboratives to serve as a resource for PQCs across the country. Learn more about how to develop and support PQCs at our website.
So as I said before, the Tennessee Initiative for Perinatal Quality Care is the name of Tennessee's collaborative. It was established in 2008, and it's funded by a grant with the state of Tennessee to Vanderbilt University Medical Center. I became aware of TIPQC back in 2012 after I completed pediatric residency and moved back home to Tennessee. And at that time, one of their projects was on improving breastfeeding among mothers across the state of Tennessee. And there have been several projects since then. I'll talk about those in a moment. So TIPQC, the overall goal is to improve health outcomes for all mothers and infants in Tennessee. And that's by engaging key stakeholders. So as the video talked about, hospitals, insurance companies, providers, the community, parents, in a collaborative to identify opportunities to optimize these outcomes and also to implement data-driven information to improve outcomes for both mother and infant. TIPQC's goals are to establish statewide repository of perinatal data for QI initiatives. So a large collection of data is available. Is to foster statewide quality improvement initiatives to improve outcomes and to lower mortality in both mothers and infants. To increase the knowledge of the impact of implicit bias and systemic racism, which we heard about earlier. We heard about maternal outcomes to Black women. And then to promote system changes by providing by provider organizations to increase the use of evidence-based clinical practices and to eliminate disparities with mothers and infants. So this is not an all-inclusive list, but this is a list of some of the hospitals that are involved across the state of Tennessee. So the first project I'm going to talk about is the Safe to Sleep project. But before I get into the project itself, I wanted to go over a couple definitions. So, so sudden unexpected infant deaths, or SUIDs, is a sudden or unexpected death of an infant, usually less than 1 year old, in which the case is not obvious before investigation. Now, after a thorough investigation, SUIDs can be attributed to various causes, such as suffocation, asphyxia, entrapment, infection, ingestions, metabolic diseases, arrhythmias, trauma, both unintentional and non-accidental. So then after a thorough investigation, if there is no cause that can be explained, and usually the event occurs in an unobserved sleep period, that's when it gets the designation of SIDS, or sudden infant death syndrome. And in 2019, according to the CDC, about 3,400 infants died in the United States from sudden unexpected infant death. And if you break up the causes, about a third of, for each category of SUIDs was caused by SIDS being the number one, and then by unknown cause in about 35%, and then accidental suffocation or strangulation in the bed in 28%. And this is where safe to sleep comes into play. So this is a graph that shows kind of the overall trends of sudden unexpected infant death from 1990 to 2019. You can see on this graph, so on the horizontal axis has the years from 1990 to 2019. And then on the y-axis, you have deaths per 100,000 live births. So you can see from about 1990 to 99, there was a considerable decrease in the amount of sudden unexpected infant death, and also in SIDS. And there were a couple programs that were initiated around that time. So in 1992, the AAP put out its safe sleep policy. And then the National Institute of Children's Health and Human Development launched the Back to Sleep campaign, which is now called the Safe to Sleep campaign. And then in 1996, the Sudden Unexpected Infant Death Investigative Reporting Form was also created. And then after that time, about late 90s, the decrease, there was some decrease, but not as drastic as in the early 90s. And now we're seeing that the rate of the deaths due to SIDS is decreasing some. However, the rate of accidental suffocation and strangulation in bed is increasing. And since we were talking about disparities earlier, there are racial differences in the causes of sudden unexpected infant death. For example, the SUID rates are higher or twice as higher in American Indian, Alaska Native, and non-Hispanic Black infants. And then SIDS accounts for this largest proportion of sudden unexpected infant death in non-Hispanic Black infants, non-Hispanic white infants, Asian and American Indian population, about 40% for each group. And then the incident of unknown causes is highest in the Hispanic infants, about 40%. And then the accidental suffocation strangulation accounts for the lowest in all racial groups, about 20 to 25% across events, but it's still occurring, so it's of interest. And so overall, right now, 2019, the sudden infant death rate's about 90 deaths per 100,000 live births. So if we look at nationwide, this is a map, and if we look to see what Tennessee stands, our sudden unexpected infant death rate is about 149 per 100,000 live births, so kind of over the national average. There's work to be done. And then if you also look at where Tennessee stands in from 2014 to 2018, SIDS was the fourth leading cause of infant death. About 23 of the deaths were sleep-related, and 21% were thought to probably be preventable. And then this is really the most recent data we have. If you look at overall, sleep-related deaths have decreased in the state of Tennessee from 2018 to 2019. However, so the blue line is the overall rate of sleep-related infant deaths. The red line is white infants, and then the green line are Black infants. And you see there's actually been an increase in their rate of sleep-related deaths. And then I just have a map of this state by county. If we look at how Hamilton's doing, the rate's about 1 per 1,000 live births. So it is on the lower end if you compare it across the state. And if you look, this is a graph that shows the contributing factors of sleep-related deaths in Tennessee when they looked in 2016. And of that, for the top reasons were unsafe bedding or toys in the sleep area, infant found not sleeping in a crib or bassinet, infant sleeping with other people, or infant found not sleeping on the back, which we'll address in the safe to sleep recommendations. So the most up-to-date recommendations from the AAP are from 2016, where they talk about SIDS and also recommendations. There are currently 19 recommendations in that paper, which you're welcome to look up and read, but I'll go over briefly, kind of summarize the most common. So the ABCs of safe sleep, which you may have heard, are infants should sleep alone, so not sleeping with anybody. If you look over, this is a flyer from the Tennessee Department of Health. So no toys in the bed, no bumpers, pads, or pillows, or extra blankets in the bed. They should be on their back, and they should be in a crib with a firm mattress and a nice fitted sheet, so no loose items in the bed. And this goes back, if you look at the contributing factors of what cause sleep-related deaths, those recommendations address the factors that were most commonly seen in causing sleep-related deaths. So to the TIPQC Safe to Sleep project, it started in spring 2020. It involved 14 hospitals. The goal was to decrease the number of sleep-related deaths through modeling and teaching of safe to sleep practices while babies were still in the hospital. And so the data that we have now, they looked from June to December 2020, and we completed through all the hospitals statewide about 1,500 audits. And when they did baseline data collection from June to September, about 70% of the audits captured weren't compliant with the AAP guidelines that I touched on. And then when they looked at compliance from October to December, they saw that it had increased to 77% in 3 months. So there's about a 10% increase in compliance, but there's still improvement that can be done. And so what is Erlanger doing? So a lot of it is about education, community outreach. So for example, Dr. Goins, one of our pediatricians at Erlanger, did an interview on This and That, which is on Channel 9 News, talking about safe sleep. That was back in October last year. And then before COVID, there was a group of nurses that set up a booth at the market in downtown Chattanooga that provided education on safe sleep. And hopefully we can get back to that. Let's see. And this is just the overall goal that we're trying to remember, is that we're trying to get these babies, by practicing safe sleep, to their first birthday and beyond. So now I'm going to transition to the Opioid Use Disorders and Opioid Exposed Newborn Project. This talk could be its own lecture in itself, but I'm going to briefly go over opioid use disorders in pregnancy and its effect on mothers and also effects on babies. So the opioid use disorder in pregnancy is a significant public health issue, which I think everybody has recognized in the healthcare community. It's defined as a pattern of opioid use characterized by tolerance, craving, inability to control use, and continued use despite adverse consequences. It can occur from illicit drug use. It can occur with use of prescription drugs during pregnancy. It can also be with mothers that are enrolled in medication-assisted treatment for already diagnosed opioid use disorder. This disorder was previously called opioid abuse and opioid dependence, but the opioid use disorder is the preferred term now. And just for some statistics, from 2015 to 2016, the rate of overdose deaths among women rose from 20% in 1 year. The opioid use disorder had gone up 4 times among pregnant women. And then 4 times as many infants were born with neonatal abstinence syndrome in 2014 compared to 1999. And strategies for addressing the opioid use disorder among pregnant women from the CDC, that in collaboration with TIPQC and other perinatal quality collaborators, is to ensure appropriate prescribing of medications, to maximize and enhance prescription drug monitoring programs, to ensure pregnant women with OUD have access to medication-assisted treatment and related services such as counseling, behavioral therapy, recovery support, and then also to ensure mothers with OUD receive adequate post-birth care, including substance use treatment, relapse prevention, and also education on their newborns of signs of neonatal abstinence syndrome. So the TIPQC OUD, OEN project is divided into a maternal arm and an infant arm, although the outcomes overlap because the health of the infant depends on the health of the mom. So it started in spring 2019, involved 13 hospitals. The goal was to implement the ACOG, or the American College of Obstetricians and Gynecologists Alliance for Women, the safety bundle that they have, which includes providing naloxone, which is a medication that's used in an emergency situation for overdose at the time of discharge. And so the percentage of pregnant women with OUD who are receiving medication-assisted treatment at newborn's discharge increased from 45 to 72%, which was an increase. And then this kind of overlaps with the infant arm, but 75% of opiate-exposed newborns were able to room in with their biologic mother for the entire hospital stay. And also, I believe 87% were able to room in for some portion of the hospital stay. 50% of babies were receiving mother's milk at time of discharge. And in June 2020, 70% were discharged home with their biological mother, which I'll talk about the significance of that in a moment. So as far as the project and the infant arm, with the increased rates of opioid use and opioid use disorder among women, there's been also parallel increase in infants born with either neonatal abstinence syndrome, which is a general term that applies to infants that have withdrawal symptoms that aren't necessarily always due to opiates. It could be due to other drugs such as tobacco, benzodiazepines, and other drugs. More recently, the term neonatal opiate withdrawal syndrome has been adopted, which the AAP, there was an article by Dr. Stephen Patrick, who's done a lot of research with neonatal abstinence syndrome in November 2020, where they talk about neonatal opiate withdrawal syndrome specifically for babies that withdraw from opiates. So health outcomes, there are several outcomes or burdens to our healthcare system related to opioid use disorder, particularly the outcomes to babies. There's risk of preterm birth, low birth weight, breathing problems, feeding problems, maternal mortality, stillbirth, NAS and NOWS, which could mean admission to the NICU, pharmacologic treatment, prolonged hospital stay, which causes an increase in healthcare cost. And then also a burden to their social work system, such as the paper that just came out from Dr. Patrick mentioned from 2011 to 2017, over 10,000 children were in the foster care system, with the reason being for parental substance abuse. So I'll briefly go over symptoms of neonatal opiate withdrawal syndrome. They're mostly divided into three main categories. There's central nervous system symptoms, GI symptoms, and also autonomic nervous system symptoms, with CNS being high-pitched continuous cry, decreased sleep, tremors, increased muscle tone, hyperactive motor reflex, and kind of most severe seizures. As far as GI symptoms, they can have feeding difficulties, and when that's one of a baby's main task is to be able to feed, it can cause poor weight gain, failure to thrive. Vomiting, loose or watery stools. As far as the autonomic nervous system, it can cause sweating, fever, frequent yawning and sneezing, increased respiratory rate, nasal stuffiness, and flaring. So from 2000 to 2016, the incidence of NOWS had increased from 1.2 to 8.8 per 1,000 hospital births. And I looked at Tennessee, it was about the same. It was like 1.5, like a 1.5 increase to 8 per 1,000 hospital births, looking up in about the same time period. In Tennessee, so far as of October 2020, there have been 600 infants with that have been identified with NOWS. And that's based on the surveillance that we do with TIPQC. And so the TIPQC project, the infant arm, started in spring 2019, involves 18 hospitals. Goals are now to, initially it was more focused on rooming in, having babies be able to room in, providing non-pharmacologic treatment in order to keep babies with mom and avoid admission to NICU. And being able to use mother's breast milk when appropriate. Now the goals are focused to education to providers, both providers and parents, improved identification of infants at risk for NOWS, and then early initiation of appropriate care for those infants. So the previous slide said it was 600 infants that were actually diagnosed with NOWS, but there were like 1,000 that were opioid exposed, exposed neonates that didn't necessarily go on to develop the syndrome. 30% did require pharmacologic treatment for their symptoms, and the median length of stay for those who did not require medication was 5 days, which is in line with AAP's recommendations. And so what's currently being done at Erlanger, as far as from kind of the treatment arm, we have EPIC order sets for the nursery to standardize treatment of opioid exposed newborns, to provide non-pharmacologic treatment first. And then in the NICU, we do have a standardized protocol for pharmacologic treatment of babies that have neonatal opioid withdrawal syndrome. And then from the education arm, the goals are to provide education to the maternal infant staff, anybody that has contact with mothers and infants on non-pharmacologic treatment, trying to remove stigmas associated with opioid use disorder. Also to provide education with OB providers to increase home prescription for naloxone for overdose, and then providing written and verbal education of what signs and symptoms for parents and mothers to look for NAS and NOWS at the time of discharge. And what's coming up? Potentially transitioning right now when we are determining if a baby needs medication, we're using Finnegan scoring, which is commonly used. But there is new technique implementing called Eat, Sleep, Console, where it focuses on maximizing non-pharmacologic methods, increasing family involvement, and using morphine as needed instead of on a scheduled way. And the goals are to decrease length of stay, exposure to pharmacologic agents, and overall cost of treatment. And this is not an all-inclusive picture of the team. All these projects do take a team effort, both locally and then across the state of Tennessee. If you'd like to get involved or find out more information, you can visit the TIPQC.org website. And then I'll leave it open for questions. Thank you.
Hello, Stephanie.
Hey, Marcel.
Hey, this is Marcel. Hey, so what are some of the can you talk a little bit about the resources we have with moms that are in the NICU for opioid use and so forth?
Like resources, like once they're discharged or
once while they're in the NICU.
Um,
Is there something that they have thought about a little bit more? Or?
Like resources for the moms, like to get treatment or?
Yeah.
Okay.
Yeah.
So
counseling, treatment.
Yeah. So one thing that with this project, it's in the second wave. And one thing we're really working on is getting a central list of resources for the mothers, which is still a work in progress. Because I feel like the kind of resources are a bit limited across the state, first of all. And so that's something that's also being worked on. So right now, it's something that we're working on, but we don't have it right this minute. But it's something that we are aware that we really need and will be really helpful to mothers because life goes on after they leave the hospital.
Yes.
So it said some babies that didn't need treatment were like discharged at 5 days. With COVID and everything, or how are we watching babies that they're on that cusp, like mom has opioid use disorder and the baby's tested positive. Are we increasing the stay for these babies that have tested positive to help like maybe catch them before they go home, or providing extra education for moms on home?
Both. I believe in the nursing, Dr. Goins will be able to speak out. I think they keep them up to 5 days unless I think they're like completely asymptomatic. That's why they also try to encourage like rooming in that period. And then also providing education on for mothers on or parents on what to look for after discharge. Thank you very much.